Hi, my name is Karen Maijer. I'm a medical doctor at the Department of Clinical Immunology and Rheumatology of the Academic Medical Center, University of Amsterdam, the Netherlands. Today I will be presenting highlights from the poster Evaluation of a Multi-Biomarker Disease Activity, Vectra algorithm in early rheumatoid arthritis and unclassified arthritis patients, presented at the Eular 2013 meeting. So, as you all may know, there are a lot of different inflammatory joint diseases, and one of the most common inflammatory joint diseases is rheumatoid arthritis. But there are also a lot of other inflammatory joint diseases, like psoriatic arthritis or inflammatory osteoarthritis, and so on. But besides that, we also know that in a subset of the patients, we cannot make any classifying diagnosis, and those patients are being referred to as unclassified arthritis patients. And our project mainly focuses on the rheumatoid arthritis and unclassified arthritis patients, so I will just go a little bit deeper into those diseases. And rheumatoid arthritis is characterized by a chronic inflammation of the synovial tissue, and this chronic inflammation can lead to cartilage and bone destruction, and thereby it can cause disability and also comorbidity. The etiology of rheumatoid arthritis is still not really known, but patients usually present with a lot of painful and swollen joints. In a lot of the cases, we see that the smaller joints of the hand and feet are affected. We know there's a prevalence of about 1% worldwide, and females are more affected than male patients. Furthermore, the disease course is very diverse because we can see a lot of patients who present with just a mild disease, presenting with just a couple of painful or swollen joints, and they can also have just a self-limiting disease. But we also know that we have a lot of patients who present with a severe disease, and those patients can present with lots of swollen joints, and also they can develop erosions. What we know is that it is very important to make an early diagnosis of rheumatoid arthritis, and also we would like to know a little bit more about the prognosis. As I mentioned before, they can be either self-limiting or erosive. And this is not only important to give more clarity to a patient, but also to be able to start the appropriate treatment early and thereby preventing joint damage on the long term. To do so to have this optimal treatment planning, we need accurate and frequent assessment of RA. And at the moment, we have a lot of clinical parameters, such as the swollen joint count or the tender joint count, and those have been developed for measuring RA disease activity. However, these measurements are very tedious and they are very time-consuming, they are poorly reproducible, and they depend a lot of on the skill and interpretation of the examiner. And in routine clinical practice, we need a rapid, reproducible, and easily performed measure. And therefore, already a lot of indices are developed, and these indices combine multiple measures into one composite score, reflecting disease activity. Several assays to measure the concentration of proteins in the blood, like cytokines, have already been investigated as a mean to monitor disease activity in RA. But the clinical utility of these individual biomarkers are very limited because no single biomarker really reflects the diverse disease activity in the diverse disease as RA. So maybe multiplex assays that measure the concentration of multiple biomarkers in one simultaneous may be better to capture the diverse disease as RA. We already know that those multiplex assays have already been successfully developed in other complex disciplines like the oncology. So Crescendo Bioscience has developed such a multi-biomarker disease activity or MBDA test. And this test assesses the disease activity in patients with rheumatoid arthritis based on a validated algorithm that generates a score. And this score can range from 1 till 100. And this score has already been analytically and clinically being validated. I will tell you a little bit more about the development of the score, because the development of this test required a lot of stages, including a screening phase, and this was followed by a feasibility study, and then by multiple stages for development. And this consists of an assay optimization, but also analytical validation, algorithm training, and finally 12 biomarkers were determined and were verified in an independent cohort. And finally, they were also clinically validated. And all the numbers of patients and patient samples in each of these phases were very large, so they can ensure that the test is highly generalizable and works for patients with different background and disease and treatment history. And the 12 biomarkers which I mentioned included in the score are the vascular seal adhesion molecule 1, the vascular endothelial growth factor, the epidermal growth factor, interleukin 6, the TNF receptor 1, the matrix metallopeptidase 1 and 3, the human cartilage glycoprotein, leptin, resistin, serum amyloid A, and the C-reactive protein. And all these biomarkers you could place in different categories. And then you have a category for adhesion molecules, but also the growth factors, the cytokine-related proteins, the matrix metalloproteins, hormones, and acute phase proteins. And together they reflect the diverse disease of RA. So then we started the collaboration between the Academic Medical Center and Crescendo Bioscience. And our objective is to perform an exploratory analysis to evaluate this score, so this MBDA score, as a measurement for disease activity in early rheumatoid arthritis and unclassified arthritis patients. And what we did, we included 126 patients of our early arthritis cohort, so the early arthritis cohort of the Academic Medical Center. And this project is called the Synoviomics, and we started this project already in the year 2000. And we include patients who have a disease duration of less than 1 year, so they cannot have an arthritis for longer than a year ago. And all the patients are disease-modifying anti-rheumatic drug naive when they start the study. And the overall goal of our Synoviomics project was to find diagnostic but also prognostic biomarkers to be able to diagnose patients in an earlier phase, but also to give tailor-made treatment. And this is all to diminish, of course, disease activity and joint destruction on the long term. So what we do at baseline, we evaluate the patients clinically. So we assess the swollen joint count, also the tender joint count, the disease activities score, the DAS28, but also we take blood and we measure the ESR and also the C-reactive protein. And of course, we also take samples for research purposes. And then the patients, all of these patients are being followed up for a couple of years. And then after 2 years, we classify all the patients in 3 groups based on their baseline characteristics and their 2 years outcome. So a patient can be in group 1. Those are the patients who fulfill the ACR Eular 2010 criteria for rheumatoid arthritis at baseline. And then, of course, remain rheumatoid arthritis after the 2 years of follow-up. The group 2 consists of patients who we cannot classify at study entry, so who are unclassified, but who are diagnosed with rheumatoid arthritis within 2 years. And the final group, group 3, are the unclassified patients from study entry throughout the 2 years, so they remain unclassified. And for this particular project, collaboration with Crescendo Bioscience, we only selected the patients in the Synoviomics project based on the diagnosis after 2 years, according to the 2010 ACR criteria, and only the unclassified and rheumatoid arthritis patients were included. Of course, the project already started in the year 2000, so initially we recruited patients based on the 1987 criteria. And the main impact that we now use the ACR 2010 criteria from the analysis perspective was on the balance of the 3 groups, because patients are now classified as RA more often by using the ACR 2010 criteria. Then, of course, the serum samples we collected and the concentration of all the biomarkers I mentioned before were measured using a multiplex immune assay, and the MBDA score was calculated using the validated Vectra DA algorithm. Then, when we look at the 3 groups based on their baseline characteristic and 2-year outcome, we included 80 patients who fulfill the ACR 2010 criteria for RA and remain RA patients. Furthermore, we included 16 patients who were unclassified at study entry, but who were diagnosed with RA within 2 years. And finally, also 29 patients who were unclassified from study entry throughout the 2 years were also included. And 1 patient more was included, but this patient was lost to follow-up, so we don't have the 2-year follow-up data. Then we looked at the baseline serum samples, and what we saw was that the MBDA score was significantly greater in the early rheumatoid arthritis than the unclassified arthritis patients. However, we did see that there was an overlap between the MBDA score in these rheumatoid arthritis and unclassified arthritis patients. So therefore, we cannot really make a cutoff of the MBDA score that could be used diagnostically to really distinguish between the RA and UA patients. And if we want to develop such a threshold or cutoff, we will need a larger cohort to validate this. Furthermore, we also found that the baseline ESR, CRP, DAS28, swollen joint count were all also significantly greater in rheumatoid arthritis than unclassified arthritis patients. Then we also analyzed if the score correlated with other disease activity measurements, and indeed we found that the MBDA score correlated significantly with baseline ESR, CRP, DAS28 within each group. So in group A1 to 3, the score correlated significantly. Finally, we also wanted to see if this score correlated in the rheumatoid arthritis patients who had normal C-reactive protein levels at baseline in the normal laboratory. And indeed, we also find that this score correlates significantly in the RA patients with normal CRP levels at baseline with all the other clinical disease activity measurements. So, to conclude, we can say that this is the first single-center study to assess both early rheumatoid arthritis and unclassified arthritis patients with this MBDA score. And we found that the score correlated significantly with clinical disease activity measurements independent of the diagnosis. However, this was an exploratory analysis, and of course, further analysis in a different set of patients would be required to validate the score really for unclassified arthritis patients. And currently the score is only validated for RA. And finally, the MBDA score may be used to assess disease activity in early arthritis patients who had low CRP levels. So taken together, we think that this MBDA score could be a rapid, but also a reproducible and easily performed assay for clinical practitioners for measuring disease activity in patients diagnosed with rheumatoid arthritis patients. Of course, we're still busy with the project, so we're still far from finalizing it, and we have a lot of future plans. For now, we only analyzed this score as a total score, and we did not analyze the specific biomarkers. So we could indeed have a look if any of these specific biomarkers are more predictive than the others for the difference between unclassified and rheumatoid arthritis patients. And furthermore, we want to have a better look at the relationship of the MBDA score with structural damage. So we hope to receive the sharp from the Heide scores from the whole cohort, so we can see and see if the score correlates with measurements for structural damage. And we hope even that we can develop also multi-biomarker algorithm to predict really the outcome data. So if patients will be erosive or not. And that's that are the highlights of this project this far. So I can imagine that a lot of people are also interested to know if there's a specific cutoff of the MBDA score, or maybe a range of these scores that can be used diagnostically to distinguish unclassified from rheumatoid arthritis patients. But we were not able to do so because we do find that there is a significant the MBDA is significantly higher in the patients with early rheumatoid arthritis patients than the unclassified arthritis patients, but there was a lot of overlap in the score between those two diagnoses. So we cannot just give a cutoff of the score to really distinguish between the two diagnoses. And if we really want to do this, we have to validate this in a larger cohort. So we cannot do this at this moment. And furthermore, it would also, of course, be very interesting to know if there are any specific components, biomarkers that are more predictive than the others of the difference between unclassified arthritis patients and rheumatoid arthritis patients. But until now, we only analyze the total MBDA score and not the specific different components. But we would, of course, very much like to do that in the nearby future. So hopefully we then have an answer to that question. And what is also very interesting to look at is to see if the baseline MBDA score could be used to predict which of the unclassified arthritis patients are most likely to convert to rheumatoid arthritis patients. However, since we are now using the 2010 criteria for RA, we saw our group of unclassified arthritis patients who fulfilled the ACR criteria for RA after 2 years of follow-up was very small. So we only had 16 patients in that group, and we thought that was a little bit too small of a group to really say something about prediction, which of the unclassified arthritis patients will convert to RA and which are not. So if that could be validated in a bigger cohort, that would be great, of course, but we were not able to do so at this moment. And of course, there are also other implications that might be there for the use of the MBDA test, because it might also be a test that can be used to assess response to RA therapy. But this is only an observational study, and all the patients who started this study are disease-modifying anti-rheumatic drug naive, and they did not use steroids or anything like that. But after the baseline study visits, all the patients are being treated just like the general clinical practice. So we cannot really use the cohort at this moment to say anything about response to therapy. If we want to do so, we need to look for all the medical data in this cohort and try to explore this, but we cannot do that at the moment. And finally, yeah, especially for clinicians, of course, the question is very interesting if this MBDA score could replace the other separate measures in assessing the disease activity in rheumatoid and unclassified arthritis patients. Of course, it's always difficult to say. It might be because we do see it correlates very well with all the other disease activity scores, but so it might be probably not the first time. The patient still has to be seen by a clinician, of course, to see if there is swelling, what it could be the diagnosis, etc. But for monitoring the disease activity later on, it might be a replacement for other disease activity measurements, and this might then be better reproducible and yeah, easily being performed. But of course, we need a lot of studies to really validate this. Thank you very much.